Hello, I'm Vincent Rajkumar, Professor of Medicine at the Mayo Clinic in Rochester, Minnesota. There are many important presentations at this ASH meeting. The first one that comes to mind is the presentation by Dr. Mariby Mateos from the Spanish PETAMA group looking at bortezomib melphalan-prednisone, VMP, versus bortezomib thalidomide prednisone, VTP, in elderly patients with newly diagnosed multiple myeloma. More importantly, these patients underwent a second randomization to maintenance therapy with either bortezomib thalidomide or bortezomib prednisone. And the main message from this presentation was that the overall survival, the progression-free survival, appeared to be the best with bortezomib melphalan-prednisone, followed by bortezomib thalidomide maintenance therapy. It appears that maintenance is important. The main other message that I think is very important to our patients and confirms my prior suspicion is that weekly bortezomib is much better in terms of neuropathy rates. The neuropathy rates were very low in this study, which used primarily weekly bortezomib compared to the usual day 1, 4, 8, 11 schedule. I think this study combined with the Palumbo study, both of which show that you can reduce the neuropathy rates substantially by using once-a-week bortezomib without sacrificing efficacy, I think constitute a major improvement in myeloma therapy, and I think change the standard of care and the practice of therapy for this disease. The second abstract that I think is very important is the study by Dr. Palumbo, looking at melphalan-prednisone versus melphalan-prednisone plus lenalidomide, MPR, versus melphalan-prednisone lenalidomide followed by lenalidomide maintenance. That study shows the importance of lenalidomide maintenance therapy, with the maintenance therapy arm having a far superior progression-free survival and overall survival compared to the other two arms. And I think this emphasizes that in myeloma, the duration of therapy and the maintenance aspects need to be explored further and may be very critical for long-term survival. And in lenalidomide, we have a drug which can be actually given long-term as a maintenance approach. The third abstract that I think is of importance is the new drug pomalidomide. Pomalidomide plus dexamethasone is being presented by Martha Lacey from the Mayo Clinic in patients who are already refractory to lenalidomide. And we are getting about a 30% response rate in patients who have failed lenalidomide therapy, and therefore pomalidomide appears to be an exciting new drug that may quickly become available for the treatment of multiple myeloma patients. Other abstracts that I think are interesting are the smoldering multiple myeloma abstract by Dr. Mateos from the Spanish group. In this study, they looked at patients with smoldering myeloma, approximately 46 patients in each arm, treated with either lenalidomide and low-dose dexamethasone or observation only. The main message from this study is that the progression-free survival seems to be far superior with lenalidomide and low-dose dexamethasone. This is a small study and more studies are certainly needed. We are planning a study such as similar to this in the United States as well, and I'm very much confident that we will be able to delay progression to multiple myeloma in the near future. Finally, Dr. Shaji Kumar is presenting an abstract on Tuesday morning, which I think is answering an important question that patients have had with the advent of new drugs. That is, whether or not transplantation in the era of novel therapy needs to be done early or delayed. And his study suggests that early and delayed transplantation in the era of new drugs is similar in terms of overall survival. And I think it's an important message for our patients. It addresses an important question that not only we have heard from patient support groups, but also from physicians around the country.